All right, everybody, welcome to the Ultrasound Lecture Series this week. Pretty excited that you're here. We are wrapping things up today. This is the last lecture of this academic year. We've had a lot of lectures that have gone basically all the way from the fall to today, and we've covered a lot of good things. And if you want to review that, you want to see what we've done, you want to kind of revisit some topics, go to the YouTube channel. We've got all the lectures posted there for you to see. But today we're wrapping things up with one more talk on ultrasound nerve blocks. So Greg Stoner, our Ultrasound Fellow this year, is going to be presenting about nerve blocks. It's something that he's interested in. He's going to cover some blocks that we didn't cover last week, so we can round out the topic and really kind of have a full discussion about what different blocks we can do in the ED. So without further ado, and with that being said, Greg, go ahead and take it over, and we'll hear what you have to say about nerve blocks.
Okay, everybody can see my screen. Okay.
Yes, sir.
Okay. As Matt said, we're going to be talking about ultrasound guided nerve blocks, or ultrasound guided regional anesthesia, if you want to be specific about it. And we're going to be talking about the lower extremity, which we did a lot of great stuff about the upper extremity and trunk last week. So we're going to be talking about the lower extremity today. So just to kind of do just a brief review as well, just in general information about nerve blocks. Obviously, we know this is a useful adjunct that could be used in the emergency department that is really helpful for avoiding opioid use, especially if you have, that kind of classic patient I think of as, your 95-year-old that falls and breaks their hip. You probably don't want to give that patient a bunch of morphine, but they might be in a lot of pain. So this is a really useful way that you can provide them with analgesia without having to worry that they're going to be sedated, and it's very safe, very easy to perform in the emergency department. Historically, everyone was worried, we have to have the, not that you shouldn't have your intralipids, available and stuff like that. But if done, correctly, safely under ultrasound guidance, the risk is pretty minimal again. And I'm going to talk a bit about, when you conduct the nerve block, how to do that in a safe manner to help avoid a neurovascular injury. And as we know, it has a very wide variety of applications. We're going to be talking specifically about the lower extremity today. So we'll kind of dive in some more things, talk a bit things that would prevent you from doing a nerve block. And if a patient has altered mental status, this would affect your ability to assess for paresthesias, because now one thing we don't generally have access to in the emergency department is a nerve stimulator. So in anesthesia, often they're using a nerve stimulator that is really helpful, especially, historically with the landmark based approach rather than the ultrasound guidance. Relying on that nerve stimulator is very key, because then you see the twitch of the muscle, you're in the nerve fiber, you pull back a little bit, because the last thing you want to do is inject into the actual nerve fibers. That can be very damaging. So you're really targeting fascial planes generally, and you're surrounding the nerve and kind of bathing it in this anesthetic, and it's going to absorb that, and then that's going to get your effect rather than injecting directly to the nerve. That's not good. So having a patient that's unable to tell you what they're feeling, that could be a contraindication, right? A patient's obtunded, they can't tell you that their foot just is feeling odd or something like that, then that's not good. Obviously, if you have an infection of the overlying skin, you don't want to be injecting bacteria down into people's nerves. That's no good. And of course, one of the big things is compartment syndrome, right? So it's a great way to provide analgesia, but if you have a patient with a severe fracture of the lower extremity, especially tibial fibula fractures, those compartments are small, right? And so the last thing you want to do is inject fluid into a tense compartment, right? So if you're going to be doing that, make sure you're talking with your surgical colleagues, talking with orthopedics and saying, hey, I'm thinking about doing this. Is this okay with you? And maybe they want to come down and measure a compartment pressure before, or get a neuro assessment so that they know what's going on. So after you've done that nerve block, they're aware, oh, the patient's going to have a completely numb leg. Well, I did a nerve block, right? So it's better to in those specific cases, talk with your surgical colleagues, kind of keep them on board, making sure that they're aware of what's going on and that they're okay with that. And of course, patients that are anticoagulated, they're going to be bleeding or at risk of that, probably not the best candidates for something like this. Although generally, you're avoiding the neurovasculature, so it's not necessarily an absolute contraindication, but it's something to keep in mind. So which probe are we going to use? Now, generally, we're going to be using the linear probe. There are some cases, some of the deeper blocks I will talk about today that you would want to use your curvilinear probe because the nerve is located deeper, but generally you're going to want to go for that linear probe. These structures are generally more superficial. It's going to give you that high frequency, good penetration, good picture. So you're going to be able to see the tissues nicely, and that's what you're going to want to use. So how do you know what you're looking for, right? So nerves are going to appear hypercoic, right? So you can see on the picture in the right here, this is an example of a fascia iliaca block, which is going to be the first one that I actually talk about. And you can see on the left side, you see the femoral artery, then you see the femoral nerve right next to it. So you see kind of this, generally they tend to kind of be triangular shaped. They don't usually look round unless you're dealing with a really large nerve, like your sciatic sometimes look more round, but often they're triangular shaped and they kind of occur inside of the fascial planes, right? And they're going to be hypercoic. Now, sometimes you can't always see the nerves perfectly, but again, if you have your ultrasound landmarks and okay, there's the femoral artery, I see the muscle. If I get into that fascial sheath, right, and as you're performing the procedure, you inject an ml or two, you'll see the fascial plane separate, and then oftentimes the nerve will actually kind of light up then, right? Because once you've surrounded it with fluid, the anechoic fluid's going to kind of light up that nerve a little bit more. So there's some of the smaller nerves, depending on what type of block you're doing, you may not be able to visualize as well, but once you kind of surround them with some fluid, then you're going to be able to see them better. And that can help kind of give you confirmation that you've gotten a successful blockade in that area. What equipment are you going to need? Well, the best needle of choice is going to be to use the nerve block needle. So you can see the top left here. That's specifically designed for nerve blocks. It has a catheter that you can attach to your syringe. So if you're going to use this, you're going to need to have a second operator with you. Now this particular needle also has attachments to a nerve stimulator. So if you have access to that, that can be a very useful tool to make sure you're not injecting directly into someone's nerve. So you're targeting a fascial plane and you're surrounding the nerve area. That's what these nerve blocks are doing. And the nerve needles themselves are designed specifically to light up. So you can see, if you look closely, the needles actually has markers on it. And the design of the actual material of the needle is designed to light up more on your ultrasound machine. So you combine that with a setting on the machine for needle visualization. It's going to be a lot easier to see that needle. If you don't have access to that, that's okay. You can use a standard 20 gauge spinal needle. You're going to want to have your syringe, you want your probe cover, your sterile setup, and of course your anesthetic. So we'll talk about which anesthetic do you want to pick, right? Generally speaking, I tend to go with 0.5% bupivacaine. Now, if you have access to ropivacaine, that's also very nice. It's going to be very long acting. And if you have something shorter duration, you can also go for lidocaine. So say, someone has a laceration and, you're only going to need analgesia, for whatever time period it's going to take you to do that. It might take you 20 minutes to do the repair. And if the patient's completely insensate, you might be able to do that repair faster, right? So that lidocaine would be sufficient for that, right? But if you're doing a fascia iliaca block on a patient with a hip fracture, they're going to have a pain for quite a while. So you're going to be better off using something like bupivacaine. Now, you can also, do a mixture sometimes. I have done that as well. 75% bupivacaine and use 25% lidocaine so that way the patient can get a little bit more relief immediately. But again, taking in mind, what is the target that you're trying to go for? Are you going for long-term analgesia for, a fracture of a bone? Are you doing superficial skin suturing? You may not require as long-term of analgesia, so lidocaine might be sufficient in that case. How much do you want to use? Well, the general ballpark number is about 20 mLs. You can use larger volumes in some of your larger patients. Now, like I said, the safe rule is generally thinking, okay, if you don't go over 20, you're going to be safe. Now, some of the blocks, you don't want to use that large of a volume. You only need a smaller volume for some of the smaller nerves. But if you're thinking about what's the maximum I can go to, well, if you just say 20 mLs, you're going to be safe. Don't use any more than that, and you'll always be fine. You're not going to overdose a patient, unless it's a child, right? Then you'd have to reconsider that. But in an adult patient, you're always going to be safe if you stick to that 20 mLs. Again, that's regardless of if you're using lidocaine, bupivacaine, because it's going to kind of encompass all that. So it's an easy way to say, okay, you don't have to worry about this big confusing chart. Just say, okay, 20 mLs, stick to that, and you're pretty safe. So this is kind of a chart showing the sensory distribution across the lower extremity. As you can see, a lot of different nerves cover a lot of different areas. Now, obviously, you're going to want to think about where's the area that you're trying to target, right? And what do you need this nerve block for? The more proximally you block in the extremity, the more blockade you're going to get lower down. And depending on where you're blocking, you might also have some motor blockade. So, is your patient going to be ambulating out of the emergency department? Or is this a patient with a hip fracture who's non-ambulatory, who you don't care about motor blockade because they're not going to be walking, right? So thinking about those considerations and determining what type of block you're going to do. So we'll talk first about the fascia iliaca block. So this is, I would say, the most common block that you'll probably be able to encounter in the emergency department. And it's also one of the easiest blocks to do. So this is very excellent for those patients that have hip fractures. Now, keeping in mind, this is going to cause some motor blockade. So your patients aren't going to be walking out of the emergency department with this, but your hip fracture patients aren't going to be walking. So that's okay. It's going to give you some excellent analgesia for the femur. You can also use it for femur fractures. Very, very, very good for covering deep down into the muscle and the bone. It's going to cover those fractures and reduce that opioid burden very nicely. Especially, like I said, in those older patients that you probably don't want to give as many opioids to. It's going to be a useful adjunct here. And like I said, it's less likely to cause neurovascular injury. Because with the fascia iliaca block, you're really not injecting next to the actual nerve itself. So the risk that you're going to, puncture the nerve bundle and have an intraneural injection is much lower. And again, the key with nerve blocks is making sure that you have adequate ability to perform in plane technique. And you're able to visualize your needle. That's very important. And always sticking to the rule. Okay, well, if you can't see the needle, stop, don't move, don't advance the needle. If you need to, remove it and start again so that you can visualize it, so that you're not pushing the needle deeper than you think it is. And then next thing you know, you are puncturing the nerve, or you have a needle in the femoral artery or something. That would be a bad complication. You wouldn't want that, right? But that's very easily avoidable if you're performing good guidance and you're able to visualize that nerve. Now with this block, you do want to use a larger volume generally. And this would be the one time that I'd recommend going for about 30 mLs. Now you're still going to do 20 mLs of your bupivacaine. However, you're going to mix that with 10 mLs of saline solution. This kind of gives you a larger volume because you're not necessarily directly, again, you can, an expansion of this that I will talk about is the femoral block. But for the fascia iliaca block, you're not injecting directly at the site of the femoral nerve. So you're going to want to have a larger volume overall. That way you have sufficient spread, right? Because some of this will potentially spread laterally and cover your lateral femoral cutaneous nerve to get some sensory coverage for the skin, if that's something that you want. Having that larger volume allows you to have spread within that fascial plane. So here's what your general setup is going to be for the fascia iliaca block. You're going to have the patient lying in the supine position. It's going to be very similar to if you're doing a central line. So you're going to have your probe kind of in the same plane as the inguinal ligament. And here's what you're going to kind of see, right? So you're going to see on the right is kind of an illustrated diagram, and on the left is what you're going to see on the ultrasound. So you see your femoral artery, your femoral nerve. Again, in this particular picture, you can't see it super, super well. It's not like you're very clearly lighting up, but you can see your landmarks, right? So you can see the femoral artery, you can see your iliacus muscle, and then in the corner there, you see your sartorius muscle. So what you're going to want to do is target that fascial plane that kind of lives in this area here. I don't know if you can see my mouse or not, but this is your fascia iliaca plane, right? So it's kind of what they describe as a double pop, right? So this first here is your fascia lata fascia. So you can either come through this, or you can come through the corner of the sartorius muscle, and you're going to feel a pop when that happens, right? And then there's going to be a second pop once you enter into the fascia iliaca space, and you pop through that, right? And it's hard to really describe, but you'll feel kind of a pop. It's almost like if you're doing a lumbar puncture, you feel that pop, kind of that's kind of that tactile feedback that you're looking for. And when you feel that, you say, okay, I might potentially be in the correct space. So what you're going to want to do is, of course, aspirate, make sure it's negative for any blood. Then you can inject about an ml, and you can see if you're in the actual fascial plane, you're going to start to see kind of an unzippering of that fascial plane. And it's going to be very easy. You're going to be a very low resistance, right? So you never want to inject your anesthetic if you feel a lot of resistance, because you're probably not in the right location. I've never done a nerve block where it's been hard to push. That's like a hard no, stop, reassess, make sure your needle's in the right position, withdraw a little bit, reassess everything. You should never be injecting when it's hard to inject that anesthetic. It should be very easy. The needle should just, the syringe should be very easy to push, because again, you're going into a potential space. It's a fascial plane. It'd be very easy to inject here. And again, you're going to see that unzippering, right? So here's another illustration here. As you can see, that target is that fascial plane, right? So one thing to keep in mind with the fascia iliaca block is you don't want to have too much probe pressure. If you have excessive probe pressure, what that can do is actually collapse that fascial plane, and it can make it more difficult for you to inject. And, if you're not able to inject, you might get confused. Oh, it's hard for me to inject. Well, it might be because you're compressing that fascial plane with your probe. So you don't want to use too much probe pressure. Keep it light. Again, your only goal here is to just visualize the structures. And these are generally superficial structures, so you shouldn't have to press hard to be able to visualize that. So keep your probe nice and light, and that'll help you kind of make sure that you're in the right space. Inject that 1 or 2 mLs. You'll see the fascial plane separate, then you're in the right space, and you can inject the rest of your anesthetic. An expansion on this is going to be the femoral block, right? So if you're a little bit more advanced and you're very comfortable with your needle guidance, and you feel like, yeah, I've done a bunch of nerve blocks before, I feel pretty good about this, and you want to get a little bit better blockade, you can do the femoral block. So this is basically going to be the same thing as the fascia iliaca block, except that you're going to be injecting directly at the location of the femoral nerve, right? So again, keeping in mind, if you're really good at needle visualization and you feel confident, it's a lot closer to the femoral artery, and you don't want to have an intraneural induction. You don't want to poke your femoral nerve. That's not good, right? So if you're comfortable with the technique, this is a great way, because it doesn't require quite as large of a volume. But again, keeping in mind, you don't want to inject into the vein, right? So here's an example of femoral block. You can see the needle being visualized here. You can see the femoral nerve. This needle is, some might just say, oh, that's precarious, right? Well, this particular provider is comfortable with that. Came in the fascial plane, you separate a little bit. It's got the needle is directly on top of the nerve bundle, right? And again, if you have access to a nerve stimulator, this would be useful for that, right? Before you start injecting, making sure you're not inside of the nerve, and that you're surrounding the nerve, you're bathing in that solution. So we're going to move down the leg. We're going to talk about the saphenous block. So saphenous block is a saphenous nerve, rather, is going to run down the whole extremity, right? Depending on what it is that you want to anesthetize, you can block it in several locations. The easiest of which is going to be the adductor canal block. I will talk about the distal block, but it's a little bit harder to do. It's harder to see that nerve. It's very small. So it's easier to get that saphenous block because you got a really good landmark. So this is going to be very useful if someone has, a laceration to the anterior, shin. It's a great thing for that. It's also going to provide excellent coverage to the medial ankle, right? So much like your femoral block would also provide the same analgesia, but with the femoral block, you're going to get motor blockade, right? So keeping in mind that this is really a sensory blockade. However, there are some nerve fibers that come off of the femoral nerve that can provide some cross coverage. So especially if you're injecting a larger volume, you might get some partial motor blockade of your vastus medialis. So just keeping in mind, letting your patients know, hey, just be cautious when you're ambulating. This might affect your motor function for a little bit. So keeping that in mind, again, and if you're, if you're doing a laceration repair and you're using lidocaine, it's not going to last as long. It maybe not really a big issue, but just making sure that you're educating your patients that so they don't end up getting a fall and coming back to the emergency department. No one wants that, right? So now this is a little bit smaller volume. Don't necessarily need that 20 mLs, but you can do 20 mLs if you want more. Again, keeping in mind that larger volume is more likely to cause that motor blockade. So thinking about what your indications are, if you really need some good deep pain because the patient, has a fracture of the medial malleolus or something like that, you might want that larger volume. So for this technique, you're going to want to have the patient positioned very much like you're doing a DVT scan. So as you can see, one thing I want to point out in this photo is when you're doing blocks of the extremities, especially lower extremity, often you're not going to have your needle entering in at the location of the probe. So like, when you do a central line, for example, right, the needle is going to be entering the skin very close to the probe, and you're generally coming in at that 45-degree angle. People are kind of familiar with that technique, right? But with the in-plane technique, with a nerve block, and on you're blocking a rounded structure, right? So you can use that anatomy to your advantage. So it's actually easier to perform this block if you enter in lateral to the location of the probe, and as you can see here, the needle is almost flat. So it's actually far easier if you come in at pretty much a flat approach. The reason for this is that if you come in close to the probe, you're going to have to come in very, very steeply, and it's going to be far more difficult for you to visualize the needle. And it's more likely that you're going to be unsuccessful with this block. But if you come in lateral to the probe and you come in with a flat angle, then you're going to be able to visualize your needle kind of entering into the to the view on the ultrasound machine, and you're going to see it in its entirety. It's going to be a lot easier to perform this technique, and you're going to have far more success if you do this. So when you look with ultrasound, this is what you're going to visualize. And again, this is why this is a lot easier than your distal block. Is most people are able to find your vasculature if you've done DVT scans. Be familiar with that anatomy. So you're going to follow your femoral vein. It's going to be about mid-thigh, right? And what you're going to see is the sartorius muscle kind of acts like the cap, the lid, right? And then you're going to have your vastus medialis and your adductor magnus on your vastus medialis is actually going to be on the lateral side of the screen, even though it's vastus medialis. Just keeping that in mind, right? And then your saphenous nerve is going to be right next to your femoral artery. Sometimes it could be a little deeper down next to the vein. Again, anatomical variance, but generally speaking, if you can identify the femoral artery, it's going to be between the femoral artery, sartorius, and vastus medialis. It's kind of live in that triangle, right? So this is kind of another view here that sometimes, it might be a little bit deeper. You might have difficulty visualizing it. So thinking about kind of the anatomy of what you're looking at. So you can see here, as you see this muscle right here, this is your vastus medialis muscle, right? And then up on top of that is the corner of the sartorius muscle here. So down in the bottom right-hand corner, that would be the location of your neurovascular bundle. But you can't really visualize it well here. So this gives you an opportunity that if you come in with your needle and you can target this fascial plane, you will get spread down to the neurovascular bundle. So if you're worried that you don't want to inject into the femoral artery for good reason, right? Then if you target this fascial plane and you can successfully, get your needle here, you get that pop, you put a couple of mLs in there, you see that spread, you're like, okay, now I'm in the right location. Then you can kind of hydrodissect where you advance your needle through that fluid that you started to inject, and it gives you kind of a pathway down so you can work your way closer down towards the neurovascular bundle so you can get more delivery in the location that you want, but it's a little bit safer way to do it. That way you're not putting it right there next to the artery. If you're worried about technique, this is another alternative that you can do, is just to kind of come in a little bit more laterally, target that fascial plane. Here's an example of a lower portion of the saphenous block. This is a below the knee technique. This again is going to be a little bit more challenging to perform because it's a very small nerve, as you can see on the image on the right here. Here's the saphenous nerve bundle there, and it's quite small. So you have to be able to locate your saphenous vein, and it's going to be located directly next to that, around the area of the tibial tuberosity. So again, this is an excellent block if you want to provide superficial sensory blockade to the anteromedial lower extremity. You have a laceration there or something. Excellent for that. But again, keeping in mind, it's a little bit more difficult to perform, and you're probably going to have more success if you do the proximal block. Again, keeping in mind, again, like I said, you can have that partial motor blockade, but it's not always going to give you that motor blockade. And if you're doing a laceration repair and you're using lidocaine, it's going to be relatively fast acting. You might be observing the patient in the emergency department anyways while they're waiting for their tetanus, et cetera, et cetera. So it may not really be as big of an issue as it could be. So timing wise, again, it might be easier just to do that proximal block, but you can target those smaller distal nerves if you want to. Next, we'll talk about the popliteal block. So this is going to cover everything below the knee that's not covered by your saphenous block. So if you want to have complete analgesia below the knee, then you can combine your saphenous block with your popliteal block. So again, you can see in the picture on the right there, you don't have coverage on the medial side, right? So that medial surface, medial ankle, not going to be covered by the popliteal block, but everything else is going to be covered by that. And so this is an excellent choice for Achilles rupture, Achilles partial tear, something like that this would be a great option for that. As I mentioned before with the technique, I would actually point out something that I would improve on this operator's technique. They're coming in closer to the probe. I'd probably move that down, come in a little bit flatter approach. Again, showing the distributions, again, pretty much covering everything below the knee with the exception of the medial side, right? So you can see that sparing of the medial malleolus, right? So if you have a fracture there, you're going to want to combine this with the saphenous block to get complete analgesia. But again, keeping in mind, like I mentioned, compartment syndrome is going to be most likely to occur in the distal extremity, right? So, if you're doing this blockade, keeping in touch with your specialist is important, right? So to perform the popliteal block, what you're going to want to do is it's essentially a sciatic nerve block, but it's directly at the location of the bifurcation between the tibial nerve and the common peroneal nerve. So you're going to want to start in the popliteal fossa with the patient in the prone position. You can perform this in a supine patient. It's a little bit more challenging, but so if the patient's able to go prone, it's going to be the preferred approach. So with the patient in the prone position, you target your popliteal vessels much like you would in a DVT scan. Then what you're going to do is track up proximally until you find the location where your tibial nerve and your common peroneal nerve come together to form the distal sciatic nerve. And so you're going to target that location at the actual bifurcation. That's where you're going to want to inject, right? Because if you go distal to that, you're not going to get complete coverage. You're either going to hit one or the other, and you may not get complete coverage. So again, as you can see, image on the right is another classic example of what I talked about, where you want to come in with that flat needle approach, because you're gonna have far more success. So when you do that, you're gonna see your needle, kind of entering in this area. You're gonna see your needle coming in from the side here, and you're gonna visualize it rather than something coming in really steep here. It's going to be harder to see. It's just going to make the technique more difficult. And you have the anatomy to your advantage. So it's far easier to come in with a flat approach. And you're going to see that come right in. You can target that location, get that block done. You can see the pictures here on the left. You can see is a dynamic video here. If you look closely, you'll see this hyperechoic structure here in this one, right? So that's the location of the bifurcation, right? So you're tracking up, so you're going to see the vessels, and you may or may not see the vessels as you track up proximally to the location of the bifurcation. You should, but you may not always, but But again, that's your landmark. So you're going to start in the popliteal, you're going to work your way up proximally till you find where the two nerves come together. Then you're going to bathe that bifurcation area. And the example on the right is what you're going to see afterwards, where you see anechoic fluid surrounding both nerve sheath areas, right? So you're going to, that tells you that you got both nerves. You're going to get good blockade. Next, we'll go and jump back up and talk about the sciatic nerve block. This is not something that I think would be as common in the emergency department. And it's also a very, very deep block. Again, it's going to give you extensive coverage of the extremity. And it's really more of a surgical anesthesia block than it is in the emergency department. Because again, you can target the specific areas that you're interested in, because it's, unless you have, extensive, lacerations or some big motor vehicle accident or something, in which case it might be difficult to get access to the area anyways. But, generally you're saying, okay, well, if I have something going on at the ankle, then I just need to block the ankle. I don't need to block the whole leg, right? So, but it is an option. So like I said, you're going to get very excellent blockade. You're not going to get that medial coverage. It's not going to cover what's in the femoral, but everything else is pretty much covered. So all that posterior part, everything that's covered in the popliteal is going to be covered by the sciatic because it's the same nerve. It's just more proximally. So you're going to be able to get some coverage of the actual knee itself, and of the femoral area as well, and the posterior leg. So to perform this block, as I mentioned, it's a little bit more challenging because this is a very deep block. So to do this under ultrasound guidance, you're going to want the patient in the supine position. So one of the techniques used in anesthesia is a posterior landmark based approach in the prone position. And that's useful because they're using a nerve stimulator to determine the location. But we don't necessarily have access to that. So from ultrasound guidance standpoint, you're going to need to have the patient in the supine position. And for this particular block, because it's so deep, you're going to want to use your curvilinear probe. And like I said, as you can see, it's very, very deep. This sciatic nerve is sitting at 7, almost 8 centimeters down, right? So you may not even have access to a needle that's long enough to even get to it. So it's, like I said, it's a much less common block that you're going to want to do in the emergency department. And you're probably going to end up being okay with doing something else, combining, a saphenous block with a popliteal or thrown femoral. You can combine a couple different blocks again, because you don't always have to do that full volume. So you could do 10 mLs here, 10 mLs there. You can get some excellent coverage. It doesn't necessarily require going for the sciatic nerve. And honestly, it's so deep, it's gonna be very difficult to access. You may not be able to see it depending on patient habitus. It could be difficult to visualize. It could be very deep, but it is a potential option. Last thing I will mention here is a posterior tibial block. This is something that you might use if a patient has a laceration to the sole of the foot. Maybe they stepped on some glass or something. This is going to provide them with excellent analgesia to the sole of the foot. So you're going to basically go to the posterior tibial area where you would palpate your PT pulse, throw your probe on there, and you're going to visualize your posterior tibial nerve here. It's going to be right next to your artery and your veins, and you're just going to come in, you bathe that small area. You don't really need much here, maybe 5 mLs. You're not going to need a large volume here because you're only doing this. This is a very small image, right? This is 2.7 centimeters. So this is a small nerve in a small area. So you don't need large volume, but you'll get excellent blockade to the sole of your foot. So it's a great way there. Often the tissue in the bottom of the foot's very tough. Can hard to get good local anesthesia there. So this is a good option for that. And that's all.